I think the introduction was more than what I will talk. Basically, the presentation will be a bit boring. The reason behind the sexual addiction itself is a misnomer term. Lot of controversies are there with the topic. I would like to clarify few, and I'm not sure whether how much I can clarify, because there are a lot of arguments and debates. I'm just proceeding. My objective will be to tell about the hypersexuality. Basically, hypersexuality, sexual addiction, sexual compulsivity, all are more or less synonymous. And whether it is a disorder as of now, what is the role of shame? Because most of the treatment has been offered are shame-based, and what are the management options and so on. So the traditional attitude towards sex was a huge shift in 1960s and 70s. You know, all the hippies and all the liberalization of the sexuality. Lot of more and different type of sexuality were being practiced, and there were many openness, many positive changes has occurred. As you know, that Marston Johnson has just developed the model of the human sexual response cycle, and he was the man of the year, and the best cover in New York Times and so on. So a lot of openness were there. Female sexuality was being discussed at that point of time, but at the same time that the tendon shift has been there. On the back of the situation, sex addiction comes. And also there were a lot of treatment options like alcohol enemas. Many people have started the 12 steps therapy for sex addiction as well. And also further worse, when the HIV has started, it becomes people become more conservative about their openness. So sexual addiction and hypersexual will be discussed as a synonymous in my next couple of slides. So hypersexuality, what it is? It's a non-paraphilic disorder of sexual desire with an impulsive component, was proposed by Kafka, and it was also defined as a clinically significant desire to engage in sexual behavior, a propensity of sexual disinhibition, or to engage in frequent inappropriate sexual behavior, proposed by Wallace and Schaeffer. Many definitions are there when there is no exact definition. So what was being proposed by Kafka, Martin Kafka, for the DSM-5, though it was rejected, he said there will be 3 or more of the following 5 criteria for 6 months, like all of the DSM diagnoses. There will be more sexual fantasies, urges, and more goals, activities and obligations, and repeated engaging in sex in response to dysphoria. So all has to be there for a significant amount of time, and it is not due to other illness, like all of the DSM definition. But it was being turned down by the DSM just due to the fact that there was not enough of evidence. There was a lot of confusion how to define it. And also there was lack of understanding of the whole situation. So there was and many people are criticizing DSM-5 authors because they have think that the pharma-driven interests were missing. So that's why that was being turned down from DSM-5, because there's no approved treatment for sexual addiction. And on the back of that, when I was presenting another presentation in Lisbon in ISM conference, while I finished my talk, few people from America has stood up and they talked to me and said, "You said there is no political interest, but do you know how much they charge the 12 steps therapy people?" I said, "I don't know." They said they charge about $30,000 a month. I'm not sure about that, but it's a huge money. So when I wonder if there is no treatment, how do they get enrolled in the system, and how do they ask so much of money? So it all is confusing, and a lot of chaos are there. So the treatment as of now is based mostly on shame, because shame and addiction are inseparable. Shame has been understood as an emotional intrinsic to hypersexuality, and shame disrupts the natural function of the self. So hypersexuality and emotional dysregulation, that is another issue. Emotional regulation means how we try to influence which emotions we have, and when we have, and how we experience and express them. It was being proposed by James Gross, and he has said that there are 3 important processes. One is the role of belief, which is largely unexplored in realm of autonomic emotion regulation and the bridge between them. So it's a complex term. Just to make it a bit simple but yet complex, that is, emotion arises in the context of a person and situation interaction, and the meaning we put to that. If we, according to James Gross, they have said that it's like there's a situation, and in a particular situation, how we give attention, that also plays a pivotal role, and our appraisal, and how do we appraise the situation and resulting in the response. And in all process, you can have the option to select, and you have got the option to modify. So while there is a option to select and option to modify, we can respond to the changes. So that is the emotional dysregulation which happens in sexual addiction due to the shame. And shame and guilt, there are not the synonymous term. In shame, you feel that there is an inner sense of being incomplete, diminished. You feel so down just because of the shame. So at some point of time, you act out. I'm presenting in my further slides how do we deal it. So in emotional regulation is the shame that whenever a substance abuser, in case of sex addiction, they have got the addiction things, they develop the shame. Just because of the shame, they feel so down, and just to relieve that, they act out. And how do they do it? According to neurobiological recent theory, as you know, those who are psychiatrists, they know that there is an attachment theory by Bowlby. According to Bowlby, that there was a attachment failure in some persons, which results in some psychiatric disturbance in subsequent life. In recent evidence has been shown that in sexual addiction and childhood trauma, there is a right front prefrontal cortex some damage, and that influences on your addiction develops as a self-regulatory negative emotions, and they have got difficulty to self-regulate proposed by Kaite-Hakis. What happens, there is a model that early life trauma by childhood abuse or neglect can impact on your right prefrontal cortex, that results in activation of the hypothalamus-pituitary adrenal axis. So more and more, the abuse and neglect and trauma, there will be some adjustment in your response. So there will be a activation of the HP axis that results in poor emotional intimacy and attunement. Attunement is referred to the degree of connectedness between two people, having the degree of that exists between two or more people. It was being first understood as realized by the parent and infant relationship, like we call it attachment. Any sort of connectedness between two people are called attunement. So when there is a problem with your attunement, you have developed less intimacy. So while the other people who have got proper sexual intercourse, they get a satisfaction out of doing intercourse. But in case of sexual addiction, they develop either less intimacy or they avoid. That's a fight and flight response. While you have got a childhood abuse or neglect, you develop a specific pattern of hypothalamus-pituitary adrenal axis. So there is some sort of adjustment. When the person further exposes to that situation, they develop either fight or flight response. If he is having a flight response, he avoids intimacy. But when there is a fight response, he acts out. So that makes, in other way you can say, some people develop shame out of their addiction. Due to their addiction and their shame, they feel so down, so incomplete. Just to act out, they do sex again, let's porn addiction or masturbation or whatever. So it's a fight and flight response proposed by the Kaite-Hakis, and it's a shame causes that way, and attunement problem were disturbed. So what do we do? In case of patients, while they are acting out, we just give a new meaning to it and emphasize more on the development of intimacy and further treatment of their problems. So, in other words, overexposure to erotic stimuli can exhaust the normal healthy sexual response, and cyber sex arousal has been found to interfere with the working memory, similar ways that interfere with the working memories in substance use. And how do you diagnose? You can use the hypersexual behavioral index. It's a 19-item questionnaire. If somebody has got 53 or more, they can be diagnosed as hypersexuality or sexual addiction. There is another, the tool that is sexual addiction screening test, or SASTR. You can apply it. There are 4 subscales, and you can identify using these scales. And how do we assess? We take history, whether there is any history of childhood physical or sexual abuse, and comprehensive sexual history, taking the biopsychosocial aspect, and social and relational history. Because I have said earlier that the people who have got sexual addiction, they avoid the emotional intimacy, whether that is also there. And some people are sex offender. We need to take the sex criminal history as well, and we can apply the sexual, the tools we have said about. So how do we treat them? We can give group psychotherapy in the form of CBT or in the form of group therapy. According to cognitive therapy, it's a behavior therapy. It is our interpretation of the event rather than the event itself. Those who are psychiatrists, they understand that people don't get depressed just because of the fact. It's about the interpretation they have. Like in your job, if you are given a promotion, for some people it's a sort of motivation. That's a token of his contribution. But some people, that is a added responsibility. They feel afraid. So it is the interpretation how you do depends on so you have to change the the interpretation and the cognitive aspect. So the CBT deals with the way people think about a situation. They need to change it. And in case of sex therapy and sexual addiction, what we do, CBT is there to treat the sexual compulsivity behavior and to give a bigger meaning to it. Shame reduction is the important factor in process of recovery. They deal with the shame. And like all other CBT, there is a formulation, they set up, identifying the core belief, managing the techniques, and escape the mechanism. In a nutshell, it's like you see the history, how it happens, you identify the core belief, and you see the management techniques for dysfunction assumption, and you know that the certain negative attention reinforces the core belief, and you need to change the attention, and while you are managing these patients, you need to see the dysfunction assumption, if any, and you need to work on that. So you have to, when there is a core belief, they will have more selective negative attention, and if you can change this attention, you can change the core belief and so on, and you can treat the patients with sex addiction. So it is difficult for someone to get a proper research-based finding, but there are very few research-based findings which have showed that CBT is helpful in hypersexuality or sex addiction, and maybe an option of treatment. And also, in some cases, you have to understand when the first time the partner discovers it, that his partner is an addict in sexuality. So it's a very difficult situation for the partner as well. So whenever you are giving couple therapy, you need to address the partner's issue. There are certain techniques being applied in couple therapy. One is called the imago technique, where there will be silent eye contact between the partners for at least 3 minutes or so, and they will sit quietly together. If possible, they can hold hands together and join counseling sessions. There are other techniques like mirroring. When one partner hears the accusations coming from the other, we ask them to mirror back. So by saying, "I heard you say," and repeat what the partner has said, follow up, "Did I get you?" So in the initial session, the session is for realization. People understand what is the problem, and when the patient get caught, mostly by the partner or some other people, they get, it's a very rock bottom situation for the couple, and their marriage is on the brink. So you have to give enough time. At one point of time, there is a lot of emotions for the patient and the partner. So you need to deal with the emotional aspect, and also individual attention has to be given. And in second phase of the treatment, in couple therapy, the partner has to reveal. The one having sex addiction, he has to reveal whatever is there. He has to be open, and he has to confess in front of his partner. And in third phase, you have to reveal the relationship. There are a lot of homework assignments and listening and everything. So sobriety, on the other hand, is a journey. And in sobriety, you have to maintain your sex. You have to get rid of all the addiction, like those who are dealing with the substance abuse. So the idea is to continue sobriety. And also you have to identify the choice points. You are exposed to a further situation. You may have the tendency to do the sex again, or you may have the tendency to act out. So you have to identify the choice point, and you need to get help from mindfulness. So what does it do? It teaches you how to do with your emotions and how to tolerate it. How do you experience the shame and painful emotions and not to act out. And also effect regulation. So in some point of time, what happens is somebody is exposed to a new trigger point. He may have a choice. Either he can go for it, or he can just retreat himself. So you have to increase his confidence. You need to accept the fact that he had got some problem with that, and he has to move on. And you know about mindfulness. There are certain techniques used in mindfulness, and it's a very good technique. And there are two types of mindfulness. One is some researchers prefer to give treatment with mindfulness the way it is, and there's a newer wave of mindfulness where non-judgmental attitude has been taken away, and they do it by being more directive. So in one study it has been shown that meditation awareness technique can help patients having sex addiction. So there are art therapy as well. In art therapy, the main goal is to reduce the shame, which is the key strategy. And also you have to understand that the hypersexuality, there are high comorbidity. Some are having OCD or obsessive compulsive disorder, some having substance abuse disorder, some having mood disorder. So prevalence of sex addiction is apparently affect the men and women with ethnicity of 3 to 6%. But if you see, many of them have got the comorbidity. So you need to address them as well. Pharmacotherapy, there are less, research-based, but mostly anecdotal and based on clinical experience. It is seen that if there is a bipolar illness on the top of your sex addiction, you need to give the patient with valproic acid and lithium. If the person has got schizophrenia, and you have to treat the psychosis first, in some patients you can use those drugs which are having more sexual dysfunction, like risperidone. So these all are, personal experience based. So there are SSRI, because at the end of the day it's a compulsive phenomena. In sexual addiction, the person has got the compulsive behavior, so you can use SSRI. Also baclofen is being used, which is a GABA agonist, which is also used in alcohol abuse. Nefazodone has been tried, and some clinician has said it is good. Topiramate has been used. As you know that topiramate is an anticonvulsant, which is good for treating alcohol and other stuff, and also migraine prophylaxis. But you can, some clinicians recommended this to be given. Naltrexone has been, offered, and some people and some clinicians has said that there was some benefits. But medication, whatever you have treated, there's no large research. So you cannot tell that this is the significantly get help. And also there are some critics, and these critics are telling, see, what is addiction for some people may be normality in some other areas. Like one fellow from India came to Bangladesh and said in an open discussion, don't offend yourself, in Punjab, in a province of Punjab, sexuality is being encouraged. They don't see it as a bad. But some part of India, like maybe West Bengal or some other part, the parents are telling it shouldn't be do. They have got a rearing a practice where sex is not being encouraged that way. So for someone in West Bengal, talking about sex is not that good. But if it is in Punjab, it is okay. I'm not, no offense. I'm just telling, and some where it is accepted. So what do you call it? Addiction may be very normal for other people, and they're saying that you are leveling someone, which is actually true. And where to decide, how to decide, and which one is same person. In some places he will get more urge to have sex, in other person he will feel confined. So what is the addiction is a controversy for many researchers. So they have raised the point as well. In summary, individual psychotherapy has to be given, and mindfulness is a very good technique for giving for treatment of sex addiction. Group therapy works better. Group cognitive behavior therapy or 12 steps therapy is helpful and being practiced in some part of the world. and medication is given to some other persons, and there's no such huge evidence. Right now, one research has been going on in Poland. One of my friend from ESSM school is doing the research. He is basically seeing the role of paroxetine on sexual addiction, and that will be published by end of December. He has told me that the whatever research he has already, the data he is getting is promising, but we have to wait for him to publish the paper. And in conclusion, sex addiction and hypersexuality is not a DSM-4 disorder, but the magnitude of problem is huge. So most of the cases, clinicians are getting these clients. Managing these patients are also a problem. As how do you treat them? At what basis? Since there is no such diagnostic criteria, there is an ethical issue of treating them as well. And also, shame reduction is the key strategy, and more result is needed, more research is needed whether we should include it in DSM-5 or 6 or not. Thank you so much. Thanks for inviting me being here. Thank you all.